Welcome to Conversations on Healthcare. This week we welcome Micky Tripathi, the National Coordinator for Health IT at HHS, on the new era where patients now have control of their health data digitally. Now, here are your hosts Mark Masselli and Margaret Flinter.
You may not have known it, but October 6th of this year was Liberation Day. Of course, that's Data Liberation Day. Advocates called it that because that was the day Americans officially had full access to their health data. Starting on October 6th, healthcare organizations were legally required to give patients unrestricted access to their full health records in digital format.
Joining us to talk about these new rules and other health IT and innovation issues is Micky Tripathi. He's the National Coordinator for Health IT at the U.S. Department of Health and Human Services.
Well, welcome, Micky, to Conversations on Healthcare.
Oh, thank you. Thanks for the opportunity to be here.
You know, these are new federal rules passed under the 21st Century Cures Act. And as we know, other government mandates and really billions of tax dollars have pushed forward the use of electronic health records. But on October 6th, advocates say patients really got access to what they wanted. Can you tell us more about that?
Yeah, happy to. The 21st Century Cures Act, which was passed in 2016, so it was passed a long time ago. It was signed by President Obama. That gives you a sense of how long ago it was passed, with very strong bipartisan support. 98 senators, I think, and an equal, sort of proportion on the House side supported it. So it had very strong bipartisan support. And of course, Vice President Biden was, very involved in it as well. It was passed in 2016. And the rules that implemented the one piece that you're referring to, which is related to what's called information blocking, actually went into effect on April 5th, 2021. So that was the date when provider organizations, certified technology developers, and what are called health information networks were required to make available all electronically accessible information to not only patients, but to other authorized parties. So provider-to-provider exchange, for example, or to a payer or to a public health agency. So it wasn't just patients, but patients are obviously very important. What the reason October 6th is really important is that on April 5th of last year was when the rule went into effect. And it said everyone needs to start doing this. But what we did is we said, let's phase this a little bit because we know it's complicated. Mm-hmm. And so with the first phase, what we said is what you're required to minimally make available is kind of a minimum data set that we call the U.S. core data for interoperability. And for those who feel like you don't know what that is, I assure you, you pretty much know what that is, because whenever you log into a patient portal, what you're actually seeing is basically defined by ONC regulations. That's like the U.S. core data for interoperability. So that's basically what's required between April 5th. And what we said is we'll give the industry 18 months to adjust to this. But then 18 months later, and that was October 6th, just a couple of weeks ago, it opened up to what's called electronic health information, which is what the 21st Century Cures Act called all electronically accessible information. So I think, as you said, it basically is all of your digital information that's required to be made available. Now, there are exceptions and all of that we can talk about in detail, but that's basically the importance of October 6th. Really is a milestone day for sure.
All right, next year we're celebrating October 6th, Data Liberation Day here in our organization. That's a given. But seriously. Patients are often afraid and anxious, I think, about their health records. I don't think they felt they had much access to them back in the old days of paper records either. Right. But that's such important information, and it may impact whether they feel like they can change providers, if they worry about it when they travel, they don't know whether they can transfer medical records easily. Do you think this really opens up more options for patients to kind of take control of their health care? To switch providers or specialists or hospitals if they want to, and have that assurance? What do we know from early experience about patients' willingness to engage in this process?
Yeah, I mean, it's still very early. I mean, to your point, people aren't really used to having this kind of access to their information in healthcare. We had a paper-based world where there was the friction of paper. People are just starting to get used to patient portals, for example. And now as we start to move into the area of APIs, as they're called, application programming interfaces, you have more apps that are developing that allow people to download their records and bring them into their own hands, like the Apple Health Record, for example, as an example. And there's Common Health as an Android version of a similar type of app. So we're starting to see a little bit of activity there, but I think that is the sort of the hope, is that what this allows is a couple of things. One is that patients have the opportunity to be more directly involved in their care, and that allows them to be able to have that information and be better participants in their care should they choose to. And one of the choices they also want to be able to make, and this affords them more of the flexibility to do that, is to move from provider to provider, for example, to not be tied to, well, I'm going to stay here because they have my records. If I had my own records, I would go to the other place, but this place has my records, so so I feel sort of forced to stay in the system. This allows them the opportunity to do that. But I will point out that all of our other rules do require that providers make that information available provider to provider. And so that's a part of information blocking, is that if a patient says, I want to go over here to your competitor across town, that provider who you're leaving is under information blocking, they would be that would be an information blocking violation for them to prevent that information from flowing to the other provider, even if the patient wasn't in the middle of it.
Micky, I want to go back to your first answer where it seemed to me that there was a lot of intentionality in the design of the rollout here. That, you gave everybody in the hospital and group practice area 18 months to sort of get ready. But we understand that some of those hospitals and practice groups are really pushing back, and they're saying they need special consideration for their infrastructure not being ready for this new reality. How is ONC assisting these entities?
Yeah. So first off, we certainly appreciate the concerns that they conveyed, and we talk to those organizations on a regular basis. So we certainly understand their concerns, and we appreciate their bringing them forward, and we certainly believe that a lot of their concerns are certainly valid in terms of change being really hard, and that this is complex. It's not a simple thing to do. And for example, if you're in a complex hospital system, this isn't just about the information that's in your electronic health record system. Most people who don't spend their lives thinking about health IT like I do, and they should consider themselves blessed in that regard. May not appreciate that. In a complex in a hospital system, you have what's in the electronic health record, but they have all sorts of other systems that live outside of the electronic health record system, some of which they may have bought like 10 years ago, 15 years ago, and that isn't a part of the EHR, and it was never designed to make information available to like a patient coming and knocking on the door saying, I'd like that information. And so the provider organization does need to deal with not only Epic or Cerner or Clinical Works and what they're able to make available, but now all of a sudden it's like, well, that chemo dosing system, that EKG system, that imaging PACS system that live outside of their systems, for example, now they have to figure out, all right, how will that information be made available?
And that's like remote monitoring devices at home?
Absolutely, yeah, right. All of those things could now, are now required to be made available as long as it's a part of what, what's defined as EHI. So that's complex undertaking. But I will say that this change has been coming for a long time. As I noted, President Obama signed the law in 2016,
and he's got gray hair now.
Right, exactly. Yeah, and it got delayed like 2 or 3 times due to the pandemic. So we certainly appreciated the pandemic. Placed a lot of stress on provider organizations, but we also feel like some of the challenges that providers and patients had during the pandemic are because we don't have the kind of interoperability that this rule is designed to rectify. So at that point, we just said, we all have to move forward at this point. We appreciate change is hard. We gave everyone a glide path, but now we all just need to get on with it.
Well, I was thinking, as you were saying that on a much smaller scale, I remember the ICD-9 code to ICD-10. And I think people asked for as many extensions to do that as they have in this. It is just kind of the way, and eventually.
That's understandable, right? And everyone's doing their jobs. Everyone's doing their jobs. We certainly don't blame them for making the effort to try to get that delayed. But at some point we have to do our jobs too and say, we're going to stand on behalf of interoperability and the patient's best interest.
Exactly. Of all the concerns that I would suspect we would hear is the question from the patients themselves or the consumers, if you will, about, well, how are you protecting my personal medical records from landing where they ought not land. People want their providers to have them. They want themselves to have them. Everybody's familiar with signing electronically or with a pen, the HIPAA releases, and who can have their records. But in this scenario, do you think patients will continue to feel that they actually own their own health data when records are being transferred between providers, maybe without their engagement? Talk to us a little bit about that. And, so many fraught issues in our country right now, but I wonder about new concerns about privacy of health records.
Yeah, well, how much time do we have, Margaret?
Yeah.
It's a huge area that you're putting your finger on here, and a couple of different dimensions to it, I think. One is just to clarify for everyone that in the United States, you actually don't own your medical record as an individual. So the idea of controlling it, you actually don't have the ability to fully control it. And that's just an artifact of the way we have built our medical, legal medical record system that under HIPAA and under the, basic, rules and laws that are at a state level, provider organizations own the medical record itself, except in one state, New Hampshire, where the patient does own their medical record. But I've done a ton of work in New Hampshire, and I can assert very confidently that no one behaves any differently up there just because the patient technically owns the record. But one very important thing that patients have in the United States is they have a right of access to their record. And that's what HIPAA grants them, a right of access to be able to show up at any provider organization in any health insurer and say, I want all of my records. And there are rules by which those records are required to be provided to them. So that's what they have, and that's what all of these rules build upon, is the patient's ability to express that right of access and say, I want all of my records. One of the things that I think from a privacy perspective, patients need to be very cognizant of, and providers who are serving them need to be very cognizant of, is that HIPAA doesn't protect data outside of the stewardship of organizations that are regulated by HIPAA. So when your medical record information is in the hands of a hospital or a doctor or a health insurer, HIPAA absolutely covers that information. And it has all the protections of HIPAA, right? They're not allowed to sell the data. They're not allowed to make it available to others in an identified form without permission from the patient. All of those things, are covered by HIPAA. But the minute that information is in your hands as a patient, meaning you have downloaded that record onto your phone, let's say, that's now your responsibility. And HIPAA no longer protects that. So one of the things I like to keep reminding everyone, and patients in particular, is you need to be extra vigilant as a patient if you decide to download that information that's now available to you and have it in your hands. And and the thing that worries me is, and this is the opportunity for a lot of education, is that, Margaret or Mark, I'm going to guess that anytime you download an app on your phone, you will say, okay, let's open the app. And when it presents to you those user agreements, you click through and you're like, just yes, fine, just get me to the app, right? That's fine. I mean, do whatever you want in every other walk of life, but with your health information, don't do that. Pay close attention to what those privacy rules say, because that user agreement could literally say, we're just going to take your data and sell it in an identified form. And because that's no longer protected by HIPAA, there is nothing against the law in a vendors or services doing that. So that's where the patient responsibility needs to come in. And just the last point is that if a patient is concerned about that, then what they can do is they can use the app that's provided to them by their provider, for example. Like the MyChart app or a Hilo app or, apps that are provided by their provider. Because if it's provided to you by your provider, it is covered by HIPAA. Even though it's on your phone, you may not realize that it's actually not data on your phone, and it's still protected by HIPAA. And so that's what I would say, is that, that people just need to be very vigilant about taking data into their own hands.
Well, that was such an important educational message for everyone. And hopefully people are listening very carefully about that. Certainly if it goes up on Facebook or other things, it's all free information, so one should be careful. I want to sort of pull the thread on this conversation and go over to sort of the security issue, because we've read reports that health data are now among the most hacked data in the world. And I'm wondering, how do we protect our health information if more of it is going out to all of us? Now, you've got two sides of this. You got the institution itself, which hopefully people are thinking about being high trust or SOC 2 or some level of security that they have to have established. We may not have all of that on our own phone or our own home computer when we have information. And then there's the other side of HIPAA patient information standards. Are they up to the task in this new era, or do they need to be reimagined as we think about the issues around security?
Yeah, no, it's a great point. So, as you point out, but just to, sort of, just build on that for a second, if a HIPAA regulated entity like a hospital or like a health insurer or a doctor's office is required to follow the HIPAA privacy rule and the HIPAA security rule, which has all sorts of provisions in there for processes that you're required to have in place, for encryption of data, for multi-factor authentication, for entry of those systems. And we know those aren't perfect, right? We all hear about the hacking into different healthcare organizations. But even with that, they at least have the requirements related to the HIPAA security rule, which provides, a pretty robust set of things that they're required to do. Once your data is in the hands of just a vendor that is not covered by HIPAA, they're no longer required. They're none of them. I shouldn't say no longer. They're not required to follow the HIPAA security rule or the HIPAA privacy rule, literally because they're not governed by HIPAA. And so that's again the area where we need to have patient education right now and patient diligence and vigilance around this, which is to say, when you have that app, and there are many, many very responsible companies. I'm not saying that that you shouldn't do anything, right? There are many responsible companies who are looking really innovatively and creatively at developing services that can benefit from, that will allow a patient to benefit from being able to take their data and making it available to the service to help them better manage diabetes, for example, or to help them with mental health, or help them with management of pregnancy, for example. There are lots of great apps out there, but that's the responsibility is now on you to say, am I confident that they have the security measures in place? Am I confident they have the privacy measures in place that are going to protect the information in a way that I'm comfortable with?
But
right
Micky,
now,
we're still seeing these.
There aren't protections around that outside of HIPAA.
But we're still seeing these big hospitals being hacked all the time, and so are your security standards up to par in terms of the ever evolving cyber attacks that are going on?
I think there's certainly more that can be done always, and and the department is certainly looking at cybersecurity at large, as well as specifically in the healthcare sector, and is doing contemplating a number of things to help raise the bar on the cybersecurity status and stature and the entire industry. So there'll be more to come from that, I think, in terms of sort of thinking about that. But in general, I think one of the challenges that we all have is that cybersecurity is about people, process, and technology. It's not as if we can just say, put this technology into place, because as we know, the vast majority of hacking events happen how? Through emails, phishing, right? And so that's a bit of a challenge that that isn't as if you can put a single technology into place. You got to be working all three of those angles to say that's how we have the kind of cybersecurity we want to be able to have.
Well, Micky, I think you are in an incredible position to continue to move the needle forward on how electronic health information works to make things better for us. And certainly experts have said that one of the ways in which we found we were not well served during the pandemic was the fact that most health systems couldn't access data to spot coronavirus trends. And also even the impact of beneficial treatments during the pandemic. Are you in the administration targeting this as an area that you can learn from to, God forbid, we need it in the future for another pandemic, or just to make things better in healthcare going forward, make us more knowledgeable and ready to respond when we need to?
Yeah, absolutely. We are, we ONC are doing a huge amount of work with the CDC on the Data Modernization Initiative, which is a big program of the CDC. For anyone who's interested, if you look at just Google Data Modernization Initiative, you'll come to the CDC website, which is really rethinking the way we think about the availability of data through the public health data ecosystem, and modernizing that, figuring out how we used cloud infrastructure to have much more efficient and effective mobilization of data for public health needs that still protects the sort of the privacy of the data from an individual level as well as from a state level, because I think one of the things that we need to recognize in the U.S., and it's been a part of the challenge, and it's a part of the beauty of the the U.S. system, is that public health just by the U.S. Constitution, is actually a state authority.
Yeah.
If you look at it, right, it's the 10th Amendment to the Constitution. It's one of the reserve powers that states have, which is public health. So we're dealing with, 50, really 64 types of jurisdictions across the country that are the ones who actually set the policies for public health. And so what we're working on with the CDC is, how do you create infrastructure that can make that more efficient? Right, we have lots of cloud capabilities. I mean, you think about what Netflix does on a day-to-day basis, right? Using cloud infrastructure to make movies available to people all over the world. How do we take those kinds of technologies and say we can do that with public health that still allows every state to have the control that they want and need over their data according to their state laws and their state cultures and conventions, but allows us all to benefit from sharing of infrastructure and more interoperability across those systems. So there's a lot of great work being done there. It's going to take time for sure, but I'm really, excited and energized by, what we've been able to accomplish so far.
Micky, we've had several of your predecessors on the show from the early days of the push for electronic health information, such as Farzad Mustashari and Anish Chopra. And they talked to us when the notion of easy flow of digital health data was just an aspirational goal. Maybe you can share with us what are some of the most dramatic advances to happen since that time, and what do you see is on the horizon, and are we going to be in the metaverse with health data at some point, and have to think through how that might work for everyone?
Yeah, my simple mind has a hard time getting up to the level of the metaverse and thinking about how that's going to affect not only my life but but healthcare. But certainly in terms of where are we? I will say one of the things that I'm most excited about in taking this role at this time is that I'm able to build on the great work that Farzad and Anish and Karen DeSalvo and Don Rucker and all my predecessors did in laying the foundation. Right, because it was a ton of hard work, $40 billion in public investment, an equal amount, I'm sure, on the private side, and then the sweat equity of providers and health IT developers getting all these systems in place, to the point that now we have 97% of hospitals and over 90% of ambulatory offices on certified electronic health record systems. Right, that's a huge accomplishment in a relatively short time, and it took a ton of work to get that in place. Now I have the opportunity to say, that's all in place. Now, how do we think about what it is we want to do? So to answer your question, Mark, directly, what are the things that already we're able to do? If you think about interoperability, for example, a lot of people don't appreciate that a lot of interoperability actually happens today. So the care quality network that now allows exchange of information across health IT, different EHR vendors. While not perfect, and while it doesn't cover all of the hospitals in the country, it covers something like 70% of hospitals and a large number of ambulatory physicians. They do 50 million transactions per day, healthcare transactions per day. And just to give you a benchmark, the global banking network SWIFT, that a lot of us have heard about because of the Russia-Ukraine crisis, SWIFT does 41 million per day. So just as care quality alone doing 50 million, that doesn't even include what Epic does within Epic's own network, Care Everywhere, and what Commonwealth does within its own network. So there's a lot of that baseline interoperability that's happening today, which is great. And if you think about, some of the things that, yes, we weren't able to get a lot of data that we wanted to be able to get during the pandemic, but the information that we were able to get, for example, on COVID vaccination rates, for example, all of those things, the immunization registries that had all of that data, the only way they got that data was from feeds from EHR systems, right? That's how they got that data, HL7V2 feeds in the background that were pushing that data into those systems. So there's a lot of interoperability that's happening, but it's not nearly good enough, right? We don't have the kind of interoperability that we want to be able to have for public health, to have payers be able to have the interoperability they want for individuals. And I'll just, give one small example. Here I am helping my mother who, broke her hip about a month and a half ago.
Oh, sorry to hear that.
And we're going from hospital to rehab hospital, a mile down the road from each other. They exchange patients, 10 gazillion times a year. They're both on very good EHR systems. And right in front of me, they are printing records out and handing them to the ambulance driver. And then at the rehab hospital, they're scanning them in, even though they're both on EHRs and they're both connected in the background. I know they are. So I'm just like, you're killing me here. You're doing this right in front of me.
And your mother is saying, what about me? What about
You're right, exactly. So there's a lot more work to do. So I don't want to pretend there isn't. There's a lot more work to do in interoperability, but a lot is already happening.
Perfect. Well, Micky, I know we're getting close to the end of our time, but there's one issue I'd really like you to comment on. Health equity is such a compelling issue for all of us in healthcare now. And I understand your office has just made an announcement regarding health IT equity. So please fill us and our audience in on with this.
Yeah, sure. So we've been doing a lot of work in what we think of as health equity by design. So basically the idea is that just in the same way that we think of privacy by design, security by design, safety by design, and software development and then business process workflow development, we think that health equity ought to be sort of a core design consideration as well. So a number of things that we've been doing is thinking first about the data, and that's the specific area that that we've been focusing on is with respect to the data as it relates to having social determinants of health data and other data like sexual orientation, gender identity included in the U.S. core data for interoperability, which is that basic data that needs to be exchanged, as well as adding additional data elements related to functional status, for example, disability, and cognitive status, for example, as other categories of data that are really important to health equity, because it has to start with those with those pieces. And then we have some LEAP awards, some innovation grants that we've just awarded that help us move further to think about different ways that we can have better use of health equity and health equity related information, and more sort of fundamental thinking of how do we bake health equity into everything that we do. So we're really excited about both about sort of having that be a part of the way that people design and think about systems moving forward, as well as being able to have innovation grants to help people sort of leap forward and invest technologies to help us sort of move ahead, which is hopefully something that everyone then will follow.
Oh, that's great. Micky, Margaret and I want to thank you for joining us today. Thank you for the knowledge and energy, passion and professionalism that you bring to your job. And we want to thank our audience for being here. You can learn more about conversations on healthcare and sign up for our email updates at chcradio.com. Thanks again.
Great. Thank you. Enjoy.
Yeah, really appreciate it.